Good afternoon. In the past few minutes, government advisers have confirmed that they are not recommending a national NHS screening programme for prostate cancer. A panel of experts has recommended that only people with specific genetic mutations should be screened in an attempt to catch the disease earlier. The decision comes despite research indicating that a universal screening programme could prevent approximately 1,500 deaths a year. More than 63,000 men are diagnosed with prostate cancer every year, and more than 12,000 of them will die. Around 1 in 8 men will be diagnosed at some point in their lifetime. We'll speak to our science correspondent Thomas Moore in a moment, but first, he's been talking to Professor Sir Mike Richards, chair of the National Screening Committee, which has come up with the latest advice for the government.
What is it about the evidence as you see it now that means that you haven't changed your opinion, that the harms do outweigh the benefits?
I think with the population as a whole, we do now know that we would reduce the number of deaths from prostate cancer a little, but we still have to balance that against the harms which are of ongoing urinary leakage, ongoing sexual dysfunction that can arise from treatment of cancer, and also the anxiety that may be caused to men by knowing they've got a cancer, even though we think it's one that won't cause trouble.
But we do have this situation, this huge divide, the north to south, the well-off to the less well-off, where people who go and demand a test from their GP are much more likely to be diagnosed at an early stage.
They're more likely to be diagnosed with prostate cancer. Whether that actually leads to changes in their life expectancy is much less certain, and it's a much smaller number. So we estimate that for every 1,000 men who get screened, probably 1 to 2 lives would be saved by it from prostate cancer. Actually, the overall death rate is very much the same.
And even though there have been the introductions of MRI scans and so on, there is nothing there that you can see that helps weed out the men who don't need further biopsies, who don't need treatment.
MRI scans have been produced advantages, and we take that into account in our estimates of both the benefits and the harms.
You have come under a lot of pressure from charities and from high-profile public figures like Sir Chris Hoy, who have said that, well, test those who are at higher risk then. Black men, those with a family risk. They are twice the risk perhaps of developing prostate cancer. They should know at an early stage whether they are likely to have any disease.
We do know that black men are at higher risk of developing the disease. What we don't know is whether they would derive any more benefit from being screened. And if we knew that, we would be offering them screening. And the problem is that, as yet, we've got very, very few patients from a black background who have actually been in any of the trials. We're trying to rectify that. The Transform study is going to be working hard to get us the data we need.
So who should be tested?
People who've got this BRCA gene abnormality, we are recommending that they get into a screening program. People who've got a strong family history, we would recommend that they have a PSA test. In some cases, if it's a very strong family history, they will also need genetic testing.
So that's what, 1 in 260 men have the BRCA gene?
Yes.
But not many of those will actually know they have it?
No, at the moment, people don't generally know whether they've got the gene. But if, for example, a man has a sister who's developed breast cancer at a young age, she may well know that she's got the gene. It should have been tested. And if that's the case, the relative, the man, would be able to say, no, I think I need to be tested, and that would be approved.
So it all comes down to a knowledge of personal health risk. That's the gateway to screening.
Certainly, the level of risk is an important factor, and if we can get better at knowing who is in those high-risk groups and whether those high-risk groups actually benefit more. With the BRCA gene, we do have evidence that not only do they have a higher incidence of cancer at a young age, but they are also more likely to die of it.
But in essence, it boils down to this. A woman has breast or ovarian cancer at a young age. She then has to get tested for this BRCA gene. She then needs to communicate that to all male relatives. They need to understand what the implications are for their own health risk.
That's true. Equally, if a man has a brother that develops prostate cancer at a young age, that man should be tested and then the relative should be tested.
But there's a huge hurdle there, isn't there? And it all comes down to often about education, understanding risk, what it means for themselves, and then having the confidence to go to their GP and say, I need to have PSA testing because I'm at much higher risk.
And we will be providing GPs with an update of all that we now know about the risks so that they can give balanced information to men who ask about PSA testing.
And that could still be overturned by the Health Secretary.
The screening committee makes recommendations, ministers decide.
And is that because you look at the hard facts, they have to be sensitive to the politics?
What ministers decide is up to them, but we will be informing them of the evidence base.
But it is the most common cancer in England, full stop. It is the only major cancer without a screening programme now. That will terrify many men.
I would like there to be a screening programme for prostate cancer, but I only want that as and when we know that the benefits outweigh the harms.